Sorry.
No, that's okay. Let's go ahead and flip to our objective slide.
Hold on. There we go.
So my goal today was to kind of review some basic anatomy, physiology, prognostic data for posterior urethral valves, review some of the techniques that have been discussed to manage and resect valves, and then review some recent literature on outcomes and approaches to fetal interventions, which I'll emphasize are largely experimental, but we'll go through some of that together. Okay, great. So kind of starting with anatomy, physiology, and prognosis. We can head to the next slide. So posterior urethral valves are a congenital form of bladder outlet obstruction that occur only in males. They're the most common cause of congenital urethral obstruction. And estimated incidence, thankfully, it's pretty rare. It's 1 to 2 per 10,000 live births. And it was first described back in the 1800s, believe it or not, and then kind of given a formal shape and form in the 1900s by Dr. Young. Yep, we can go to the next one. Yeah, so this is a diagram of the posterior urethral anatomy, and the posterior urethra really comprises all of the urethra proximal to the urogenital diaphragm extending down from the bladder neck. Embryologically, this is derived from the urogenital sinus. And the striated sphincter is kind of the distal limit. And this is important to kind of know for our future discussion of how surgery is done. We can go to the next slide. So there are 3 types of valves that are kind of described in the literature. And I'll be honest, the vast majority I've ever seen are really type 1. I've seen maybe 1 type 3 in life, but type 1 valves appear to emanate kind of from the vira montanum. We'll see a really nice example of that in a few slides. And they travel anteriorly just proximal to where you saw the prostate and the membranous urethra kind of meet. So if you can imagine, it's almost like these little sails of tissue on either side of the viro kind of extending back towards you if you have a camera seated at the membranous urethra. Type 2 valves kind of arise from the vira montanum and go both posteriorly and superiorly to the bladder neck and are not known to definitively be obstructing. And they haven't really been described in the literature in recent memory. Like in the last 50 to 80 years, I don't think there have been any publications that really looked at this. And I did try to check that before today's presentation, I couldn't find anything. And then type 3 valves are an annular ring, kind of like a congenital stricture, found at a variable location relative to the the prostatic urethra where the viro sits, and up to the membranous urethra, that sphincteric junction. That's seen in about 5% of cases. Next slide. So fetal urine production begins in weeks 11 to 12 of gestation, and it's really responsible for maintenance of amniotic fluid volume. However, it's good to know that some of that volume will be accounted for by fetal transudate and exudate. So by week 26 of gestation, about 90% of the amniotic fluid is fetal urine and no longer transudate exudate. So in children with valves, this becomes important because you may not see oligo or anhydramnios until that period, if that makes sense. And then impaired production of fetal urine, in the late 2nd and early 3rd trimesters for that reason, can lead to poor, unfortunately, pulmonary alveolar development because the lungs are able to mature because the baby is literally swallowing the amniotic fluid, which contains several important products for fetal lung maturation. So that's something else to kind of think about. In the literature, you'll see people describe, pulmonary and renal survivors of valves, and this is exactly what they're referring to. And the severity of, oligohydramnios and pulmonary development restriction is really related to the degree of valvular obstruction.
Want to say something? No? Okay.
So posterior urethral valves can have pretty dramatic effects on the bladder, urethral and ureteral and renal function as a sequela of severe bladder outlet obstruction. And this is really for life. And we're going to go in a couple slides, we'll go through an important diagram that I think everybody, especially our residents, should know. Bladder outlet obstruction is initially compensated by increased voiding pressure and detrusor musculature hypertrophy. So when we talk about, the bladder kind of looking trabeculated, on an initial VCUG, this is why, right? That change in detrusor architecture unfortunately predisposes to increased collagen deposition, particularly type 3 collagen and fibrinogen deposition. So there's essentially scar tissue forming around the bladder in utero because it's working so hard. And if you can imagine, this results in a poorly compliant bladder that functions more, I kind of make the analogy of like those rubber workout balls that have a thick wall and aren't super easy to kind of push in or to make re-expand, unlike a balloon, right, which is soft and compliant and easily expands and contracts. And so that leads to impaired bladder emptying and elevated storage pressures. Next slide. Oh, sorry, I think we missed one there. No? Yeah, thank you. And so what this does is it leads to global injury to the urinary tract, basically top to bottom. The picture you see to the right is actually of one of our own patients. And you see kind of a kidney bean shaped structure. Sorry, Anna, I can't draw the mouse around it. But there are cystic lesions in the periphery of the parenchyma. And the parenchyma itself is kind of bright relative to the tissue above it. And that is not something you'd want to see. That's indicative of cystic dysplasia of the renal parenchyma, which is not really recoverable parenchyma. It's permanently damaged kidney tissue. So why does this happen? So as we said before, elevated storage pressures of the bladder push back on the upper tract, impairing the drainage of the renal pelvis and the ureters. This results in hydronephrosis with or without reflux and variable levels of renal dysplasia. There are some series that suggest that, in the presence of severe cystic dysplasia, the chance of end-stage renal disease at the time of delivery is upwards of 60%. And then increased renal pelvic pressure leading to renal tubular dysfunction and reducing the urine concentrating ability can lead to some polyuria. So you may be surprised initially by how much urine babies are making at birth, but it's not good urine, right? It's not urine that has been filtered appropriately. Because of the collecting tubule damage, if you can imagine, that's where your receptors for vasopressin and everything else are to help kind of pull, control how much water is being allowed to get into the urine. It's really poorly concentrated urine, and it's just kind of being dumped. And this high volume of urine is pushed into this abnormal bladder, which doesn't empty completely and perpetuates the issues with reflux of urine, upper tract pressure damage, and upper tract injury. Next slide. This is a really important diagram. I think this is one that everybody, who is going to take a board exam in urology should kind of know and internalize, because it really just illustrates everything we just talked about, and it explains how the valve bladder kind of, it says evolves, but really it sort of devolves over time, right? So kind of starting on the upper left side at about 11 o'clock, you see urine is stored in these hydronephrotic kidneys that's draining into this poorly compliant bladder. That increases PVR, that increases stretch on the bladder wall muscle, that increases deposition of collagen and fibrinogen, deposition in the bladder wall, and increases bladder wall hypoxemia because the bladder wall is trying to work. It doesn't have good blood flow because a lot of it's now made of scar tissue and it's not compliant. And so that increases oxygen demand that it can't meet. And so more scarring happens. And then there are increased bladder storage pressures. Those pressures are then transmitted to the renal pelvis, the renal tubule, specifically the collecting ducts, really sustain a lot of damage. And then there's polyuria due to this renal concentrating defect. And now this poor baby is attempting to void at higher and higher voiding pressures, and so on and so forth. Next slide. So thinking about it kind of from a top to bottom perspective, in terms of lungs, you can see pulmonary hypoplasia that's so severe it's fatal. If the children survive, most of the current literature suggests that there aren't long-term problems for the most part. There is some emerging research that I believe is pending publication that suggests that maybe we need to be watching these pulmonary survivors a little more closely over time. I think some of it may be getting presented at the SPU, so we'll stay tuned for that. At the kidney level, we talk about, glomerular injury, and then obstructive uropathy, which hopefully is reversible renal insufficiency at birth. And so when we treat the child at birth, and we'll go through this soon, the mainstay of treatment is getting rid of the obstruction as quickly and efficiently as possible, to kind of help that reversible injury heal quickly. Unfortunately, dysplasia, as I said before, is a strong predictor for needing dialysis and eventually renal transplant because it's irreversible. It's permanent damage that limits growth of the kidney. And then we talked about tubular injury. So you can't limit sodium and water loss. And so you can see what's called nephrogenic diabetes insipidus. And I highlight this mainly for Andrew because they'll ask you about it on your board exam and they'll say, what do you do for what's the cause of polyuria in this patient? And the answer is nephrogenic diabetes insipidus. And then they'll ask you how you want to manage it. And sometimes it is so severe and it puts so much work on the bladder that you have to think about placing an overnight catheter. So it's a question that'll come up. In terms of bladder function, there's poor sensation, hypercontractility, because it's really trying to push, poor compliance, and eventual myogenic failure. The bladder just kind of, for lack of a better term, it poops out. And so that can contribute to kind of overflow incontinence type pictures and poor emptying. And really, one thing I emphasize to all my families, especially at the fetal consult stage, is that bladder problems are lifelong and that they change with age. We do not expect a child with a valve bladder to potty train normally. We do not expect them to, necessarily walk away from us with totally normal bladder and kidney function at any point. We have to keep a close eye on them because these things change over time. And the ureters themselves, we'll see some examples, that there's poor contractility of the ureters. So the ureters are supposed to kind of peristalse like the bowel, meaning that you're supposed to have a top-down signal that says, okay, I'm pushing urine down, and then the next, little plexus says, okay, I'm going to push urine down further, et cetera, et cetera. That doesn't seem to be as true in animal models of valve bladder. The ureteral peristalsis is affected. The ureters themselves are poorly contractile and they don't co-opt and they don't transport urine efficiently. And so you may see some improvement in ureterectasis. We'll see an example of that. But most patients do have some element of chronic hydronephrosis. And the most common features of presentation at prenatal diagnosis are really oligohydramnios, bladder distension, and we'll talk about the hallmark of that, and bilateral hydronephrosis. Next, yep. And so this is the keyhole sign of the dilated posterior urethra. This isn't the most perfect example, but it is one of our patients. And what lends that keyhole appearance is the dilation of the posterior urethra, right? It's not a round shape when the bladder's distended, it's actually round with a little kind of keyhole shaped tail, right? And so that's what we're talking about when we describe that. And these are other stigmata of oligohydramnios that I think are important to know, and they are testable. So in terms of Potter Fossey's, there's low set ears, kind of a beaked nose, prominent epicanthic folds and a downward slant to the eyes. There can be pulmonary hypoplasia causing respiratory failure and severe limb deformities. And again, this is all related to extrinsic pressure from not enough amniotic fluid volume to cushion the baby in utero. So these are all the sequelae of that. So the goal initially is to first, of course, make sure that we're able to offer sufficient pulmonary support if needed. And that can involve, giving mom medications prior to delivery if delivery is expected to be really premature, and understanding that ventilatory support may be needed like pretty much right after the baby is born. The next thing that we have to think about kind of in the postnatal space is establishing lower urinary tract drainage as quickly as possible. Now here, I don't know that it's usually a 5 French feeding tube. I apologize. That was a carryover from practice from fellowship, but usually we try to establish drainage with a small catheter because these children are born early. And that's really what that was getting at. And then obviously you want to make sure that, the catheter is secure, that it's not coiled in that posterior urethra. So you can see the picture to the right. This is a baby that was born recently here with valves. They have a bladder that's distended, bilateral hydronephrosis, a very hypertrophied bladder neck. You can see that in the box. And then that's the posterior urethra, that spinning top appearance. That's how dilated the posterior urethra is. So you can imagine that with placing a catheter, it'd be easy to accidentally coil the catheter there. So there are several tricks you can use, glide wires to guide things, or catheters with a small stylet to kind of bypass, the issues with coiling in the posterior urethra and really make it into the bladder neck. It's important after you establish drainage to kind of follow the renal function really closely. The first 24 to 72 hours, creatinine is really a reflection of maternal kidney function, not fetal. So you can't necessarily trust it. So that's something I also tell families, when we're counseling them before birth. And then because we kind of expect most of these children to have some degree of vesico-ureteral reflux, and they have to have an indwelling catheter until, surgery, we would typically start them on prophylactic antibiotics pretty early. An evaluation is usually with a renal bladder ultrasound and then a VCUG. And valve ablation is done when they're clinically stable. And we'll go through my selection criteria for that in a little bit. Next slide. So in terms of prognosis, this was a kind of an important paper. There have been a couple iterations that came out after that. But the nadir serum creatinine in the first year of life is a really powerful predictor for needing dialysis in valve patients. So what's the best their creatinine ever gets to, after ablation? And that'll kind of tell you, where the patient's going to live. So 20 to 50% of patients with posterior valves across the board will proceed to end-stage renal disease throughout their lifetime. But the good thing to know is that if their creatinine is less than 0.4, 0% seem to need a renal transplant in their first 5 to 10 years of life. And if they're over 1, 100% of them will proceed to renal transplant. So that's kind of a useful benchmark for counseling patients. There are a couple of other studies that suggest the threshold for needing a renal transplant at nearly 100%, maybe closer to 0.85. But I use 1 as the cutoff in clinic counseling. Next slide. So you may see something known as VERD. What is VERD, right? So posterior urethral valve patients with high-grade unilateral reflux into a poorly functioning kidney, they may have a preserved contralateral renal unit with absolutely no reflux. And the theory here is that that reflux to one kidney serves as a pop-off mechanism for the bladder pressure and kind of trashes one kidney, but protects the other. So we hypothesized, previously that this would mean they have better long-term renal function because they have it, but unfortunately, only 30% of children with with VERD end up having a normal serum creatinine value by the time they get to 8 to 10 years of age. So this doesn't seem to be panning out to be the perfect protective mechanism that we had originally hoped it would be. Next slide. And sorry, was somebody going to make a comment? I apologize. I can't see or hear anybody.
I know the audio is not working in the room, so we're on my laptop.
Okay.
We'll make comments at the end. No, continue. Just thank you.
Sure. Okay. Of course. Okay. So let's review some management and techniques. And this is kind of there's some interesting updates here. So the procedure is dependent on multiple factors, mainly the size of the urethra for valve resection. So ideally, the least invasive approach to addressing obstruction in these kids is going to be endoscopic resection of the valves. But this is really challenging in really premature babies or patients with a very low weight. Prolonged urethral catheter drainage is typically not recommended because eventually it does lead to catheter displacement or urinary tract infections. And vesicostomy has actually been compared to valve resection. And there are some proponents of early vesicostomy and delayed valve resection, but these studies did not demonstrate superiority because the risk of bladder prolapse or stomal stenosis was pretty significant. So children were coming in with issues related to the vesicostomy. So TUR is still kind of considered the first step gold standard. This is generally done with passage of a 7.5 or 9 French cystoscope. And you can use different techniques. A Bugby electrode has been used by some who choose to use diathermy. I'll explain why I personally don't do that. Other techniques that we'll go through include the cold knife or Collins knife, with or without diathermy, and the holmium laser. And generally speaking, I like these pictures a lot because I think they do a good job of kind of diagramming where we're cutting. But generally speaking, most of these valves are type 1. And so you see how that valve is kind of extending in the sagittal view, from the verumontanum to the membranous urethra. And so you make an incision at 5 and 7 o'clock to take down these sails of tissue. And then just in case there could be some anterior fixation, it's usually recommended to consider making an incision dorsally at the 12 o'clock position. Great, next slide. So this was highly contested. Do you use diathermy or do you use cold knife? Because the visualization with our small endoscopic equipment is already so limited. But there was a small trial performed by a group in Chennai, India, where they demonstrated that there's a higher risk for urethral stricture with diathermy. So in that top picture, you're kind of seeing cold knife, and in the bottom, you're seeing a diathermy technique. And so this group recommended kind of shying away from using cautery if you can. Okay, great, next slide. So selection criteria, how I do it, generally speaking, I wait until the child is closer to 10 pounds, able to tolerate general anesthesia. So in these kids, pulmonary status is kind of key to making sure it's safe. And that their fluid balance is acceptable, if they're on dialysis. And then I usually discuss circumcision if the family is agreeable to reduce their infection risk. And we will discuss that data soon, actually. Next slide. See if the video will play, God willing. It looks like it's fast forwarded.
Yeah. Let's see. Oh.
Okay, so that's the verumontanum. You just saw the bladder neck before, and these are those sails of tissue at 5 and 7 o'clock, and they're pretty profound. And so you'll see kind of the cold knife come forward, and they're going to cut at the 7 o'clock leaflet. Maybe not. Okay, there we go. And this is essentially how we cut that tissue away on both sides. And usually it requires multiple repeat passes of the scope. These scopes are not continuous flow, so we don't want to rupture the bladder. So usually it involves kind of going in, emptying the bladder, going back in, and then kind of coming back and repeating the cuts. You can go to the next slide. So the end result is kind of like this view, right? So you can see here, we've cut the sails on either side, and there's kind of a little cut line at the 5 and 7 o'clock position, but you have a clear view from the membranous urethra to the bladder neck. And these are pictures from that same case. So you can see on the left side, we have a very hypertrophied bladder neck with no flow. And on the right, we've kind of reestablished flow in the bladder neck, and posterior urethra are starting to kind of improve in their appearance. My personal practice is a catheter for 24 hours with a void trial and a VCUG at 3 months to make sure that we don't see residual valvular tissue. Now, that's kind of controversial. So there are groups that have been huge proponents of relux cystoscopy in 100% of patients, other groups that say that that's overly aggressive and extra anesthetic in an already, young, premature, very sick baby. And so there have been suggestions about, when to kind of include a possible relux cystoscopy. And these indications include things like recurrent infections, residual valvular tissue seen on VCUG, and then others use a surrogate measure of residual valvular tissue or stricture that is, unimproved or unresolved hydronephrosis or reflux. And the reason they do that is because VCUG is wrong about 50% of the time about residual tissue. So long story short, we have a low threshold to think about a relux cystoscopy if we're concerned or if the child's getting recurrent infections. Next slide. Now, I mentioned vesicostomy as another option. Some groups do this up front to kind of decompress the bladder and avoid a Foley catheter, but the issues can come with, stomal prolapse or stenosis. It's a temporary diversion technique. It allows the bladder to fill and cycle. And the reason for that is, so you see here, the bladder is exposed at the dome, right? Where it's attached right below the umbilicus to the urachus. And then we actually transect the urachus and create a stoma there and bring it up to the skin. And so the bladder is below this, right? Kind of dependent. So that allows some urine to pass out of the urethra, but some to pass out of the vesicostomy. And the vesicostomy acts as like a valve to offset pressures to the bladder and the upper tracts. And so for that reason, there are several proponents for this. I think there may be an ongoing study, I believe with Cincinnati and Colorado, where they're kind of comparing this to upfront TUR and long-term outcomes and reoperation rates. So hopefully we'll see some of that data soon. And others, there have been studies that said, what if you're defunctionalizing the bladder with a vesicostomy? And some studies have shown that bladder capacity is best in those who undergo primary ablation. But I think that overall, most studies of vesicostomies have shown that the bladder is still able to cycle a little bit, and none of these studies have long-term follow-up. I think this study only had a couple of years follow-up and one post-operative study per patient. So I think this is something we'll actually have more data on in our own transplant population. And I think Shannon is presenting, our data on transplant after vesicostomy, which could kind of give us a lot of guidance on this specific area. Next slide. So the other option that we didn't discuss earlier is upper tract diversion. So what that means is you actually bring the drainage tube of the kidney, the ureter, out to the skin in some form to establish drainage of the upper tracts. And this is if, you're worried that the bladder is so thick that even if you create a vesicostomy, the ureters are actually compressed from the thickness of the bladder wall. And so you just can't get good enough drainage. And so these are rarely done in my experience with this patient population. But I've seen, kind of the sober Y ureterostomy that you've seen there, or the ring ureterostomy, I would say is much more rare. But the most common of all of these is probably the distal ureterostomy. Circumcision, as I mentioned before, I always counsel patients on this, and this is because we have actually decent data that it reduces the risk of urinary tract infection by 10%, and that's really significant. And at baseline, kids with posterior urethral valves have a much higher risk of UTI than the general population. So anything that can reduce their risk is helpful. Next slide. Follow-up plans for these patients. It's really, taking good histories on what's happening with their bladder, considering urodynamics kind of closer to the time of transplant to get a sense of their storage capacity and function, as long as they're otherwise stable. And then helping parents understand that toilet training doesn't look the same for their child, and that they may need to use, aggressive timed and double voiding. There's always strong consideration for, kind of bringing in pelvic floor muscle retraining in some form, and or, CIC with or without an overnight catheter if you're concerned about retention and infections. And alpha adrenergic blockade has been shown to relieve sphincter hypertonicity and really relax the bladder neck in kids with high post-void residuals. And I actually had, there is an abstract on this, but I don't think the manuscript was ever published, that showed that it's actually safe to give in infants for this exact purpose. And many will advocate for oxybutynin to decrease, end filling pressures in a poorly compliant bladder. Next slide. So we can talk for just a couple of minutes here. I apologize, I may have to run into the operating room, but we can talk for a couple of minutes about outcomes and approaches to fetal intervention. So the mainstays are really vesicoamniotic shunt, amnio port emplacement, and then experimental procedures include fetal cystoscopy. Can you hit the YouTube link for me, Anna?
I can try. I'll have to read.
It's okay if it doesn't work.
It works. Just have to. Can you see it? No.
Yeah, I can see
You
it.
can see it. We can't see it.
Oh, that's sad. Well, that's not helpful. So you can stop
know.
it.
I don't know why we can't see it.
Is it on a different window? Because it's pulled up in Google Chrome.
Yeah, I don't know.
That's okay. Just stop it and we can go back to the presentation. That's a cool video to see how vesicoamniotic shunts are placed. For those who haven't seen it before, I'm happy to share the link. And then they also show how amnio ports are placed. So vesicoamniotic shunt is a shunt that's typically placed kind of below the level of the baby's umbilicus, and it goes straight into the bladder, and it establishes shunted drainage from the bladder to the amniotic space to repopulate the space with fluid. And so theoretically, this could help avoid some of the stigmata of severe obstruction, that kind of Potter syndrome picture that we talked about earlier. Amnioport placement is done for children who are, really preterm gestation with anhydramnios. And so in those cases, there may be an indication to think about doing serial infusions of sterile saline to just keep the baby from being compressed by the uterus. And so that's what that video kind of goes through. And then fetal cystoscopy is highly experimental and less common and only done in a few centers around the country. But we are exploring it here as a possible option for our patients. The selection criteria are highly variable, but most will use beta-2 microglobulin of less than 8 on the fetal urine, and confirmed, severe ludo with, oligo or anhydramnios and really poor appearing kidneys and a distended bladder. And most of the time, you can go past these slides. These are just kind of summaries for those who want to reference, but most of the time we would use some kind of very small fetoscope and a curved sheath. People have used infusions of water with a syringe, that's called hydroablation, or like a holmium laser, almost like we would use for stones to kind of ablate the tissue, or a diode laser. And one group even described just using a gentle pass of a soft, like a glide wire, through the posterior urethra to try to ablate. But the success rates of these procedures, which is kind of summarized in those previous tables, were really less than about 50%. So most of the children were going to the OR after birth if they made it to birth. So this is an area that merits a lot of further experimentation to see if it is something that we can feasibly and safely do for patients. Next slide.
You're done.
Thanks everybody for listening, and I'm sorry I couldn't hear questions during the talk.
Thank you, Vinaya. I don't have any questions. I just want to point out a few things. First, thanks for doing multiple things in the morning, covering the division for a drill and operating room, and also presenting to us. Just for Andrew to remember that there are a few things that we inherited historically, because pediatric urology, believe it or not, is a very new specialty. So there is a lot of things that we just keep on learning by osmosis. For instance, this whole concept of 3 types of valves is actually very questionable. Reason is because this was based on autopsies or stillbirth, and there was a lot of details telling you that when you put a catheter, you distort the valves, and that's why the valves are always type 1. But, okay. The second thing that we inherited, for instance, you look at Campbell's, and they always talk about every UPJ has 15% chance of reflux. I'm not sure if it's still present in the most current edition. And the last thing is they talk about primary and secondary reflux, by the way. I'm somebody who believes that there's no primary reflux. It's all secondary to bladder pathology. Reason why it's important to remember most of the details that Dr. Bhatia shared with you is that it's very common to be called for a patient prenatally and have those questions like male, keyhole sign, oligohydramnios, dilated ureters, dilated kidneys. And it's also common to talk about VERD, the VERD concept. Used to be very common to consider that VERD is a good sign. It's not anymore. So that's why also it's common for the board questions to come VERD. What is VERD like? And you need to remember that. We recorded this, right?
Mhm.
Thank you. Thank you again. Thank you, Vinaya. Any questions?
Questions. I think the only thing that I really differ from the talk is that I don't weigh for 10 pounds. If it's a infant, then you can see that there's something, I do able to access the bladder through the urethra, which is rare.
And I don't know if Vinaya mentioned this, but sometimes she may have mentioned it, like a common question is you have a patient, you cannot do valve ablation, and you do the vesicostomy, but then do you do the valve ablation at a certain time with the vesicostomy in place? And the answer is no, because you don't want to be incising the urethra or the valves and keep the urethra dry.
Okay.
No, and I should have said that, Waleed. I didn't. I should have mentioned that.
That's a common question that you do the valve ablation and then keep the urethra dry, and this is why it's recommended not.
Would you ablate and then close the vesicostomy?
You would do that.
Oh, okay.
And that's a correlation to doing like a TURP or any sort of urethral procedure. If the urethra is dry, it increases the risk of structure.
Gotcha.
You will hear that again in the adult
Okay.
for other things.
Thank you.
Thank you, everyone.
Thanks.